All right, guys, we'll just give it a 1 minute and I'll get started. I gotta try to book it a little bit early, so maybe I might try to end like 10, 15 minutes early. I just gotta get home, but we should be able to get through this lecture plenty of time. All right, so talking today about evidence-based medicine in spine and research design. I think we're all familiar with evidence-based medicine and kind of what it means, but there's actually a technical definition of it. I think it's important to kind of go over, and also its origins. And research design is important because we're all familiar with our way our orthopedic studies are designed, but that's kind of because orthopedic studies and in general surgery studies work in better in like a certain way. For example, retrospective comparative studies. It's hard to do kind of prospective studies, but we'll get into that. We'll talk about what happens when in the past people have tried to design well-designed prospective studies. So as a quick outline, we'll talk about what is evidence-based medicine, talk about levels of evidence, which we're familiar with, research design, and the types of studies. And I'll give some credit to NASS evidence-based medicine course, which I actually took because I was trying to see, if I can be on their kind of committee or whatever. So as part of that, you take this course for like CME credit and all this stuff. But that's some good kind of concepts in there that we'll cover. So evidence-based medicine is a combination of three things. It's the combination of best scientific evidence along with the practicing clinician's clinical experience and combining them with patient values. And the best clinical sort of practice comes from combining all these elements together. There's actually a definition that was put forth by David Sackett in the British Medical Journal in 1996. That's the most commonly used definition today, which is a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So the important thing here is, you need some systematic research to find out what is good and what works for patients. Not relying solely on clinical expertise, but it also doesn't rule out clinical expertise. As we all know, that's invaluable. And the human judgment is extremely valuable in terms of providing patient care. This approach to patient care emphasizes knowledge of the current and best clinical evidence for making treatment decisions. As we all know, I Think Therefore I Am was made popular by Billie Eilish, but actually before that, there's this French guy, René Descartes. He not only was involved with mathematics, but actually kind of helped develop a lot of things in terms of scientific method as we know today. And he also purported in medicine, he said, when it is not in our power to follow what is true, we ought to follow what is most probable. And he talked about the application to medicine as well. The question is, in spine, what is the truth about, what is the actual truth in spine care? How do we know what is, actually the best for like a patient with one level spondylolisthesis? Would they, is it truth, like if they're stable spondylosis, do decompression, should they always be fused, etc.? Like, we don't really know. And there are some good studies that point evidence to one way or the other, but this is kind of like a continual search. And current best evidence may not be the highest quality, approximate truth may not be clear, but is best we have currently. René Descartes came up with this hierarchical pyramid of evidence. So at the very bottom is mystical evidence, and then magical, and then rational thought is one way to kind of apply clinical practice. And then dialectical is sort of combining rational thought and group thinking into coming up with a consensus choice. Empirical implies that you have a set of observations. So like if you think of like empirical methods for like scientific research and stuff, you have a repeatable set of experiments that you do, and you can come up with a deduction from that. And scientific evidence is a little bit more rigorous than the empirical evidence that you have. So if you have a bunch of, the way I thought about it was empirical evidence kind of gives you an association, and scientific evidence is a subset of that, where you have these strong associations, but they may not be clinically relevant. So it's kind of finding the right fit within what the specific field that you're working in. The timeline of evidence-based medicine kind of starts with Descartes, as we talked about, and then more recently, in 1972, Archie Cochrane, and you may be familiar with that name because of Cochrane Reviews. He was a Scottish physician who wrote this book about effectiveness and efficiency in 1972, and he sort of further defined, what studies in evidence-based medicine, how it should be structured. Prior to that, it was a lot of, just sort of case series and people putting forth papers on, if you look back through the early spine literature, you have, the seminal studies about cervical fracture dislocations. And, these are all case series of people that had maybe, let's say, a cervical spinal cord injury, a fracture dislocation, and the treating surgeons put forth their treatment options. But was it the right thing to do? Maybe. Was it the best thing to do? I mean, it's all those things, those questions that pop in our mind that we don't have the best evidence for. Like I said, he wrote this book, Effectiveness, Efficiency, Random Reflections on Health Services. And one thing he noted was that because resources will always be limited, they should be used to provide equitable treatments for patients in properly devised evaluations. And then he stressed the importance of randomized control trials to really get at the truth of a treatment. And as we know, this Cochrane collaboration is named in his honor. The next guy who kind of came up with expression evidence-based medicine, Gordon Guyatt from Canada, he co-authored this article in JAMA in 1992. He mentioned that evidence-based medicine de-emphasizes intuition, unsystematic clinical experience, and pathophysiologic rationale as sufficient grounds for clinical decision making, and stresses examination of evidence from clinical research. So it's a lot more, putting thought into what you're doing for research rather than just kind of, firing from the hip, just because that makes rational sense. And also that's just what you were taught to do, and kind of going with the flow, so to speak. And he also emphasized the importance of physicians being able to read and analyze literature as well as clinical importance. So they were among the first to talk about, incorporating analyzing literature into medical training. And then David Sackett is the guy. He's actually in 1996 defined evidence-based medicines as that definition that I put forth earlier. He organized principles of the systematic review into 6 steps, and then he further added to the previous 2 people's emphasis and popularized the importance of the systematic review as well as the randomized controlled trial. But not everyone took this willingly. There's some backlash against evidence-based medicine, mainly among successful practicing clinicians. They thought this was a dangerous innovation, and it's perpetrated by the arrogant to serve cost cutters. Excuse me, and that this suppresses clinical freedom. It's probably hard for us to imagine what it might have been like to be a practicing physician, like 50 or 100 years ago, where so little was known about the pathology, and you're taught a certain set of ways, and you're basically going with what you know best, and not really looking into what other people are doing or what has been done to kind of do the best thing for your patient. The other thing is that people thought that cookbook medicine would be kind of another thing so that everyone does the same thing and with little variation in treatment. But Dr. Sackett, his retort was several. He states in his article in 1996 that that purchasing managers would attempt to hijack evidence-based medicines to cut costs of healthcare, but he stated that this would be a misuse of evidence-based medicine because it shows a fundamental misunderstanding of its financial consequences. And for example, to assess the efficacy of a diagnostic test, you need good cross-sectional studies of patients suspected of heart rate disorder. So, while you may need like a good randomized clinical trial or a systematic review, you may not. That doesn't necessarily mean that that's the best evidence. You can do like smaller studies. So his retort was not everything, not every clinical question needs a randomized controlled trial or meta-analysis or systematic review. They can be smaller, things from it. And he didn't sort of get rid of clinical experience. He kind of weighed that pretty heavily as well. And another thing that needs to be talked about is human nature. For example, like when we go to our bathroom scale and it delivers bad news, we just hop off and then hop back on again just to make sure we didn't misread the display, put too much pressure on one foot. But when the scale delivers good news, we just kind of smile and head for the shower. So you always kind of rethink the bad news, and then when the good news comes, you don't really delve into it. But by uncritically accepting evidence when it pleases us and insisting on more when it doesn't, we subtly tip the scales in our favor. So evidence-based medicine tries to get rid of that. And we'll talk about kind of practicing evidence-based medicine as well as validity in terms of the technical definition. So validity of a project or research can be split into 2 different items: internal validity and external validity. So validity in laboratory research is the degree to which the result or of a measurement or study is likely to be true and the correct reflection of reality and free of bias. So it's free of systematic errors. Internal validity is where the laboratory bench study, if the outcome is a function of the variables that are measured, controlled, and manipulated, so it's repeatable. And if one variable changes, then it reliably changes the outcome in a certain way, and this is demonstrable. Now, external validity is where you can have the same study, and the results can be generalized and reproduced in other laboratories under similar conditions. validity in clinical research is a little bit of a different concept. I mean, you can apply the same concepts of validity, but when you have clinical studies involving humans, it becomes very difficult because of large numbers of uncontrolled variables and ethical constraints on human research. As you can imagine, it becomes challenging to evaluate the soundness of conclusions from clinical studies, and then the validity of conclusions from these clinical studies improves with the quality of the experimental design. So when we're talking about validity in clinical research, one way to assess it is with the rigor of the experimental design, so like a hierarchical evaluation. And this concept leads us to, the well-known concept of level of evidence. So there are studies that, that are more rigorous than others, and that's one way to kind of assess which ones have more internal and then subsequently external validity. So evidence-based medicine involves, again, combining the best research evidence with the clinician's clinical expertise and the patient values. So let's talk about scientific evidence first. So the evidence-based medicine does not depend on all the research evidence available, only the best. So again, you can have like thousands of articles on, let's say, degenerative spondylolisthesis, but you just need to find the best evidence that's that you need to, think about for your specific case, and weigh that into consideration. And you can do this by reviewing and rating the relevant literature. And this leads to the use of best practices guidelines in clinical medicine. For example, we have best practices guidelines for spine trauma. What should a surgeon do with a cervical fracture dislocation, or similarly a lumbar spine trauma, or then there's other guidelines for, let's say, cervical myelopathy or cervical radiculopathy. But these guidelines are rooted in the best available literature, and then they form grades or recommendations based on these. It provides a self-correcting mechanism with the practice of evidence-based medicine, and also reduces the influence of factors of outside of clinical decision-making process. So, one thing you can imagine here is when physicians have relationships with, let's say, new technology or things that maybe haven't been proven yet, is it really best scientific evidence to be using that in, a setting where we know we have higher success rates? So it promotes ethical decision-making. Clinical experience, we can think about clinical experience, from us, me as a young physician attending, or like you guys as residents or fellows, and, let's say even med school, you have kind of didactic education, right? Which is starts in undergraduate and medical school. And yeah, you do some clinical stuff in medical school, but mostly it's didactic. And we know in medical school, didactic learning is quickly outdated. And the famous saying, half of what you learn here in medical school is false. You just cannot tell you which half, and and that your textbooks become quickly outdated. And what you want to learn afterwards is impossible to completely assimilate, because the volume of literature just explodes every year. And so then finding the relevant literature that you need to stay on top of your field becomes hard. So moving on towards kind of the next stage in training, residency and subspecialty training, and then just practice, you have clinical experience. And this is probably a lot more important than education in terms of how we handle our patients, right? Like I think in residency you come out with, by the end, a certain confidence about treating an orthopedic problem, just because having seen it so many times, and have your subconscious kind of guide you what is the probably the appropriate trajectory of treatment, et cetera. There are some flaws with kind of relying solely on clinical experience. There's well-defined psychological effects that you guys may have heard of. There's a primacy effect, where you might recall a lot of things early on in your training, and then you might also recall a lot of things towards the end of your training. That's the recency effect. And then you might also really remember that strange, unusual case in the middle of your training that always sticks out. But you might miss a lot of the kind of low-level cases that you just never think about again. This is demonstrated in multiple different settings, and that peak is called a von Restorff effect. So if you have someone recite a bunch of animals and you throw the word briefcase in there, they'll remember that because it doesn't fit with the animals. And then you might remember like or crow and horse, and then cat and cow, which you did in the beginning and end, but may not remember the ones in the middle. So similarly, clinical experience can kind of maybe lead you astray in that sense. And finally, the last part of that Venn diagram is patient values. So each patient brings kind of a unique knowledge, social experience, and set of beliefs that's important to consider. But patients continue to rely heavily, if not solely, upon the recommendations of the physician. So in the end, it comes down to, you and taking into account, their beliefs and their social experience. So the implications of practicing evidence-based medicine differs for each person. For us as the clinical practitioner, we have to use the best evidence to help decide which treatment is appropriate for a patient. And again, this helps minimize physician relationships with outside entities that may not be as beneficial to patient care. The clinician scientist needs to plan studies to incorporate a higher level of evidence, so that they're looking at it, evidence-based medicine, in a different sense in terms of what is the best evidence I can get out of this study, or highest level of evidence. Then finally, the discipline of practicing EBM, you have a increase in experimental rigor of the literature, and this raises standards of evidence. So classic thing is garbage in, garbage out kind of studies, where if you don't have a good hypothesis going in and don't really have any good research design, then you're not going to get good data, and you may not get any meaningful conclusions from it. So having good experimental rigor and then having good studies raises the bar for us in our field. And finally, with healthcare, it's important for evidence-based medicine, that we continue to practice it, because the concept of quality and value are now fundamental to how new initiatives in healthcare, especially the last 10 to 20 years, have come up. So the language of quality that that are placed in all these healthcare bills and stuff like that, it's actually comes from evidence. So if we don't have good evidence to talk about it, then we can't even talk about healthcare reform. So now, kind of shifting gears to the actual level of evidence, kind of the nitty gritty, and the research design. My goal here is not to bore us all with kind of like statistics and kind of the design of each study, but just kind of give a overall higher level kind of overview. First, we'll talk about therapeutic studies, and these are studies that are investigating the results of a treatment. For example, these are mostly what we do in surgery. We're assessing the results of a certain surgery or a certain technique, certain approach, use of a certain implant or biologic in the patient. Prognostic studies investigate the effect of a patient characteristic on the outcome of a disease. And so these are, could be within orthopedics, but mainly within kind of the realm of medicine. And you have diagnostic studies, so investigating a diagnostic test. Again, this could be also within the realm of orthopedics, but less likely. And then you also have economic and decision analyses. Then, as we're familiar with, there's study designs. You have meta-analysis, or we start at the bottom. You have, the low-level evidence, which comes from editorials, expert opinion, or ideas that are published. The next level of evidence are, case reports, and then if you have a series of patients, the case series. These, articles basically don't have any intervention. They don't have any control group. You're following, patients over time and reporting how they improved or did not. And basically, there's no set validated outcome measure. It can be whatever, the authors decide to report. A cross-sectional study is, a study where you observe a cohort at one point in time and determine, the current incidence of the problem. A case control study is looking at patients who have one outcome versus those who do not. For example, let's say within orthopedics, you have infections. You identify a cohort of postoperative deep surgical site infections versus those that do not. Then you look back retrospectively to identify the influence of certain risk factors, such as uncontrolled diabetes. That would be a retrospective case control study. You have two arms, one is a control arm, one's a case, and then you're looking back retrospectively. I will say, a lot of our orthopedic studies fall within this category, and they may not be labeled as a case control, but they'll be labeled as a retrospective comparative study, kind of the same thing. You have an endpoint that you're interested in, and for example, let's say pseudoarthrosis. So you have a cohort of patients that have a non-union versus those that do not, and you're looking back retrospectively to identify any risk factors. So that's a retrospective comparative study. Prospective cohort study is a little bit different. You're enrolling patients consecutively and following them over time. For example, if I want to look at non-union, I enroll people now. I identify the risk factor I'm interested in now. For example, whether it's a new implant or a new biologic, or if I'm enrolling people with a certain kind of like systemic disease, and but I identify it now, follow them over time. I have, for all intents and purposes, equal groups. Then I identify their endpoint as how many non-unions developed in each group. The randomized control trial is probably the highest level of sort of a prospective study that we can devise. You're taking patients, and we'll talk about this in the next few slides, but you're randomizing them to two groups, and you're keeping them blinded. So you have it for a simple two-armed kind of randomized control trial. You have an intervention arm and a control arm, and you randomize patients to each. So one popular thing, that we always talk about in spine is the treatment of type 2 odontoid fractures. I think there's an AO study going on for burst fractures as well, because there's few controversies in spine that stand out as much as, let's say, treatment of type 2 odontoid fractures, and therefore a randomized control trial is probably the best study designed to answer that. So patients can be randomized to a non-operative treatment or operative treatment as long as they fit the rigid inclusion and exclusion criteria. And then also, ideally, the people analyzing the study at the end of the case, at the end of the study should be blinded to the treatment. Obviously, you can't blind the patient to treatment because you have to explain to them beforehand, say, hey, here's a surgical intervention, non-surgical intervention, and then, they have to sign off on their consent saying that they're part of the study. So, they know that they're not going to get the surgery at a certain time point, right? So this is what makes randomized control interventions in surgical fields hard to do. If you had, for example, let's say, like if you're doing like a cardiology randomized control trial, you have a placebo, you have, the standard of care kind of drug, and then you have like another new interventional drug. You have a kind of a 3-arm study, and you randomize patients to those, and you can kind of get away with, blinding the patients because they don't know what they're getting, and you can blind the clinician as well. And then finally, systematic review and meta-analyses are kind of the overarching, I would say, what am I looking for? The summaries of any of the below. So for example, you can have systematic reviews of the randomized controlled trials, or meta-analysis of randomized controlled trials. That would be the highest level of evidence you can attain. You can also have systematic reviews of case control studies or prospective cohort studies. When you start to mix and match, like a systematic review, cohort, or case control, then that level of evidence should probably be downgraded to the lowest level, right? Because, it's kind of like the weakest link, so to speak. This is kind of in the pyramid format of what we just talked about. So again, critically praised topics, systematic reviews, and meta-analyses are kind of the summation and filtered information. And meta-analyses, going to a little bit as well, have more rigorous statistical methodology. So that kind of further adds to their reliability. Now, therapeutic studies generally, so we talked about, the randomized controlled trials being about a 1B level of evidence. Then we have most of our orthopedic studies, which fall in this realm of either 2 or 3, where you have retrospective comparative studies or prospective studies here. And, with one of the things we'll talk about is we talked about the difficulty of randomizing patients to surgery. There are, in cases, for example, if I remember right, sports medicine, you can have sham surgeries, you can have, smaller procedures where you can get away with just, kind of having a placebo arm, let's say, in the surgical field. So that's one, kind of aspect where we can get a higher level of evidence than maybe we thought. So we kind of go into the critical elements of a good study. We'll talk about hypothesis, where we succinctly state the PICO, and we'll go into what that is. Then we also need to critically analyze the methods of the study and then results of the study. What did they find? The PICO, as you might have heard, it's refers to a population, intervention, comparison group, and outcome. So every study should succinctly state this at whether it's the end of usually it's the end of the introduction, right before you delve into your methodology. In 1 to 2 sentences, it needs to state this. Basically, the study needs to identify what patient population we're working on, what is the actual intervention that the patient's undergoing, is there a comparison group, and there may not be, and what is the specific outcome of interest. There's problems with this in that you can make it too broad or too narrow. So for example, one example of too broad is, what is the fusion success for treatment of axial low back pain? This is too broad because there's potentially many different confounders, and it can be unanswerable. Basically, what kind of axial low back pain? Is it discogenic pain, facetogenic pain, like strains? Is it, the fusion success would be significantly affected by that? Then there's a whole host of patient factors that go into, consideration here. So there's potentially way too many confounders. And then one example would be too narrow would be, what are the outcomes of post-auto fusion with and without cement augmentation in patients with osteoporosis and degenerative spondylolisthesis? So at first seems like a decent enough question, but it's too narrow because it limits the generalizability of conclusions. So you can, you can hyper focus on a small group, and you may unintentionally introduce selection bias because it has such stringent criteria, and then it's just not even generalizable in your findings, even if you have enough people and get the right, power calculation, et cetera. So as we talked about earlier, these are kind of the domains of the studies. Therapeutic studies, what we kind of focus on, and then the methodology of how the study is done. And we usually aim for, let's say, like a well-done prospective cohort study, or, again, a well-done kind of retrospective comparative study. Randomized controlled trials would be nice, kind of hard to do. But the main thing is we have to have a good question going into the study. So here we have, for example, going into the specifics of what the PICO question is P stands for population. One of the things is look for the amount of heterogeneity in the population. In part, this is determined by the inclusion-exclusion criteria. If you have too homogeneous of a population, it's not very generalizable. An example given here, you have, let's say, is in middle-aged male amputees suffering phantom limb pain, and then we'll go into, is gabapentin compared with placebo effective in decreasing pain symptoms? So here, I mean, this seems pretty reasonable. Middle-aged male amputees and suffering phantom limb pain. It seems like you would have a big enough group, and it's not hyper-focused because there's probably plenty of those, for example, patients that served in the armed forces that may have fit this criteria, or people with like vascular issues or diabetics. Then the other thing is considered is the population in a single center or multi-center. This also affects heterogeneity. In general, multi-center is better. Intervention, and here you need to consider, how many providers are part of this, were patients enrolled consecutively, and what is the standard of care across comparison groups, and is the intervention itself actually feasible? Here in this case, gabapentin is feasible. So it's a very cheap drug and it's easy to administer. But if you're talking about, something surgical, is that reasonable for, if it's like some hyper specialized surgery, is that reasonable to study if like not everyone can access it? So another question to think about before you go into design a trial. C stands for comparison group. You obviously, need a comparison group to have a higher level of evidence, whether it's placebo or like, let's say the standard of care. Otherwise it becomes kind of a case series, automatically lowering your level of evidence. But you want to look at the quality of intervention in the comparison group and look at selection bias, as well as the amount of crossover between groups. And then in addition, were these groups treated equally outside of the named intervention? Again, this would be another example of confounders. And finally, the specific outcomes that you're measuring. So primary versus secondary measures, and are these measures actually validated for what you're looking for, and are all important outcomes included? So here we're looking at decreasing pain symptoms. So presumably you'd look at VAS, leg, let's say. Then moving on to the next part, looking at methods. So study design can be prospective or retrospective. It can be a comparison group or single arm and randomized. So talk about a prospective randomized controlled trial, prospective cohort study, and then as we talked about before, retrospective case series, or if there's comparative group, case control. Randomization should be done so that allocation is concealed and that the groups are similar. So this is to balance confounders. Improper randomization introduces bias, and then because then you might have patient and provider expectations like we talked about with the surgical RCTs. And then consecutive enrollment, and then do you have a proper follow-up period for the patients? And finally, statistical analysis. You need to know if an appropriate sample size determination was done. And power analysis, as we know, is the ability to find a difference when a difference truly exists. Now, there's one thing to clarify with a priori versus post hoc analysis. So a priori power analysis always needs to be done when you're creating a prospective, study, because that makes sense. You want to know when you should stop enrolling patients, and you think you've enrolled enough to find a difference. The one thing that I never understood is when reviewers would always, comment back about retrospective studies and ask for a post hoc power analysis, because I've talked to many statisticians, and they all say that post hoc power analysis is meaningless. But actually, one explanation that was given to me that actually makes sense is that it's a power calculation when you're doing it post hoc. And the power calculation is so that, for example, if your retrospective study found a difference, then you don't really need to do a power calculation. If you retrospective study didn't find a difference, the power calculation tells you, do you have enough patients in your group to find that difference? And it's a little bit back and forth with the statisticians. Some say you don't need it, some say you do, but it seems like all of our orthopedic journal reviewers say it's very important to do it. So just something to think about. Again, if you're doing a randomized controlled trial analysis, it's more to think about, do you need to do intent to treat analysis, which is the appropriate way of evaluating randomized control trial. Otherwise, if you have significant crossover and you lost your randomization, then you maybe need to look at it as a NAS treated analysis, which then essentially downgrades it to a prospective cohort study. And then finally, for results analysis, you look for results. You need to think about how much how dropouts you have in terms of your patient enrollment, missing data. In general, you can account for up to 20% of missing data and still be okay. This is what generally statisticians are okay with different imputation methods. Depending on what kind of analysis you're doing, you'd be okay with about 20%. Crossovers between groups and then subgroup analysis are when those are important and should be done. We need to make sure that they're in the study. And then finally, analyzing it, did the randomization work? So this is kind of more in the discussion aspect of the study or just outside of it. And are the conclusions supported by the data? And is the study reproducible? And do these results actually apply to a clinical patient population? Again, if we talk about the patients, questions too narrow may not be applicable. And finally, last set, we'll just talk about the types of studies. We talked about randomized control trials. So not to belabor this, but it is the gold standard for determining whether one intervention is superior because it reduces bias. But again, there's rigid inclusion-exclusion criteria that randomized control trial for type 2 odontoid fractures, if I remember right, they need to be over a certain age, shouldn't have another concomitant axial spine fracture, or and I forget, there must be like an age limitation. So it's really hard to enroll people. Not only are those fractures not come around often, it's really hard to enroll them because a lot of these people get screened out easily with exclusion criteria. Finally, clinical equipoise is the term for where you have genuine uncertainty in the expert medical community. And this becomes a problem because RCTs are good at answering questions where there's clinical equipoise. Like as a clinician, I have no idea what's the right answer. But most things we do, for example, if I see a really displaced type 2 odontoid fracture in a patient, older patient with poor biology, I'd say that may not do well with non-operative treatment. So I would lean towards surgery, but then again, that's not demonstrating clinical equipoise there. So one of the barriers to RCTs can be demonstrated in our spine literature in sport trials. For looking at operative versus non-operative treatment of lumbar disc herniations, patients are randomized to operative or non-operative treatment. There's a high crossover rate from the non-operative to the operative group within 3 months. This suggested that both the clinicians and the patients, or both, felt that surgery is beneficial. So then you continue with your intent to treat analysis. I mean, you could, but then you reduce your power to detect real differences. So the trials actually went with as treated analysis. And the limitations of randomized control trials, again, in spine specifically, there's clinical spine populations are very diverse. You have differing anatomy, morphology, pain, disability states, even for the same kind of pathology. You have different health states, different socioeconomic states, et cetera. So you can add in rapidly evolving technologies, and then there are hundreds of variables and confounders to account for. Prospective cohort study, we talked about, tracks patients over time. Here, the main weakness is selection bias. So if you're able to enroll patients equitably between two groups and demonstrate no baseline differences, then you might be okay. Retrospective studies are bread and butter. We talked about case control and case series. The case controls are nice because, this isn't like in medicine where you have the numbers of patients are a lot higher, maybe like 10 to 100-fold higher. Here we have less numbers of surgical patients, and for all intents and purposes, the outcomes of interest for us are a little bit more rare. Infection, or let's say like duotomy or postoperative weakness, et cetera. So all these sorts of things are just much more rare. So using case control studies is an effective way of doing our research, and hence why we do it a lot. Case series are good for providing overview of a new technique, procedure, technology. and kind of putting it out there in literature, introducing clinical effectiveness of this new technology. And finally, meta-analyses are mathematical combination of multiple clinical trial results, and then strengths include when there are large number of patients. But weakness of this, you got to think about is publication bias, because most of literature tends to be biased towards positive results. And although this shouldn't be the case, but unfortunately it is a lot of negative results may not be ever published. And finally, there's also a lot of other kinds of studies that we never covered. For example, one main domain is cost effectiveness study, like hospital charges, cost to charge ratios, qualities, cost acceptability curves, etc. It's, one of the things that we've all been familiar with over time here is the rise of administrative databases. We know it's difficult to conduct quality prospective studies, so administrative databases provide us with this vast amounts of patient data, and you can generate meaningful evidence from this retrospective data. The one problem is they lack outcomes details, right? There's no real patient-reported outcomes. So these may include state inpatient databases, the nationwide inpatient sample, NSQIP, insurance databases. We're working on, Dr. Su is, part of and Dr. Patel with getting the American Spine Registry here at Northwestern, where, hopefully we can track spine patients, all spine surgeries, in a large registry over time, and with meaningful spine-specific patient-reported outcome instruments that will actually kind of allow us to compare, treatments. And finally, last, let's say, given a practical example, for example, is MIS TLIF superior to open TLIF? If you ask like two clinicians, one who does open TLIF, one who does MIS TLIF, you're gonna get two different answers. But can you answer this with a, level 4 case series? No, because it's not comparative. So you'll have one, let's say, physician who's really skilled at MIS, and they'll publish good results. You have one who's really skilled with open, they'll publish good results. Can you do case control studies? What specific outcome are you choosing when you look at case controls? Is it a specific outcome measure? Is it a fusion rate? Is it other measure? That's where the pitfall comes. Sure, you can choose one or two. And again, you may find differences here and there, but what is the appropriate way to look at it? Prospective cohort, allows comparison, but again, permits some selection bias. And then an RCT is difficult to do with this because it's difficult to achieve equipoise, like we talked about. And then there's so many other considerations to consider, like not every, TLIF is made the same, for example, different levels of spondylolisthesis, or what level is being operated on, the amount of, the grade of the spondylolisthesis, how much central stenosis is there. And finally, a learning curve for physicians for MIS versus open. And then another example would be optimal treatment for an adult with Degenerative scoli in a single level of RDIC. There's, again, if you're looking at case series, it's not comparative. If you're looking at case control, what outcome is chosen. Administrative databases that include these, massive cases with Degenerative scoli lack outcomes. With prospective cohorts, there's multiple treatment options. And then finally, when you look at RCT, significant heterogeneity. So, and there's other things to consider, again, the treating surgeon. So there's so many different variables to kind of touch on, but hopefully this was like a, kind of a quick overview on, things to think about when looking into treatment options for patients. And I think for us, my main takeaway is with evidence-based medicine, it's kind of our go-to in how we think about patient problems. So you got to combine the best available evidence, as I discussed. You got to take into account patient values as well as your clinical experience. Alrighty, so I think that's it. So I can stick around for some questions.
Hey Sri, that was a great talk, man. I'm giving a similar talk at a Stryker course in a couple of days. I wish I had your slides. They're done so well. So thanks for the summary.
I can send it over.
So 3 points I wanted to make.
Yeah.
One, so when we talk about evidence, I think you did a great job of summarizing. I think it's important for everybody on the call to realize that we're talking about the body of evidence, right? You made a very good point on how one study can show one outcome, another study done a little bit differently can show a different one. But when we ask, let's just say a resident, what the treatment of spondylolisthesis is, we're really looking for what a collection of studies would say. And that's where a systematic review would come in, a meta-analysis, all of that can tell a lot more than just one particular study. And that goes actually for the sports studies as well. Randomized controlled trial data is very valuable, but it has to fit within the body of evidence one way or another. Second thing I want to say, you're absolutely right. Recency bias, surgeons are classically guilty of this, right? We treat 3 patients, they all end up the same way, and then we change what we do based on the last 3 patients that we treated. That is an asinine way to practice surgery and practice medicine in general. So that's where evidence-based medicine comes in, is making sure that we know what the literature says. Doesn't mean we have to make every decision based upon 1 or 2 studies or a meta-analysis even, but to know that that is our counteracting effect to recency bias, and surgeons are all guilty of it, just making a decision based on the most recent case. The final thing I wanted to say is, you talking about the difference in studies and how to study different outcome measures is really important. I mean, the BMP saga is a classic example of this, right? So we have all these trials where they're powered to show the difference between a fusion rate between BMP and iliac crest bone graft. So like 300 patients in each trial. Lo and behold, 10 years later, we're using that data to measure cancer rates. And all of a sudden, cancer rates are increased in these groups of patients that are powered for fusion rates, right? I mean, and so everybody, so as spine surgeons, we didn't really understand at that time that the way to study cancer is not through a randomized controlled trial, because you need hundreds of thousands of patients. It's such a rare occurrence, right?
Right.
Infection, tumor, all these things. And so we were quick to jump to a conclusion that BMP causes cancer based on our inability to understand what it was about the study design and what we were trying to show. So everything you're presenting here, I could see somebody hearing and be like, you know what, we don't necessarily need to know this, or it's not pertinent. It's actually pertinent in the last decade, and one of the most important lessons that I think surgeons can learn, for new technology. So yeah, great job, Sri. I think it was a great summary.
Yeah, that's a great point. And, especially I think you being on kind of both sides of research, like the basic science side and the clinical side, you kind of get, both perspectives on, like how to design a study. Like in, like a well-done clinical study, I feel like is hard because there's so many variables to consider. Versus like, if you design like a animal experiment that you're looking at posterolateral fusion model of something, and you can kind of rigidly, design your experiment, and it'll go as planned as long as you execute it fine. With clinical studies, I think there's got to be a lot more thought into it, and it's one of those things that I never really thought about it for a while either. You got to keep looking into kind of the details of each thing.
You're absolutely right, but the beauty of a clinical study is that sometimes you'll find results, that are unexpected. Well, you'll find that in every research study, but in a clinical study, that unexpected result may be more valuable than a basic science study. Like a basic science study is so you can try to control as many things that you can control. In clinical studies, you're right, you can't. But you'll find something like a little nugget in one study here and a little nugget in another study there, and that will add to the body of evidence. Again, it's a body of evidence, not just one study. And you talked about that, but I think it's really important to know that, and that's why I never ask residents or fellows to quote one study, right? Like we tend to do that on the boards. Oh, who wrote the landmark paper on spondylolisthesis at L4-5 in 36-year-old women? You know what I mean? Like that's like an asinine way to ask that question, right? Like what does the body of evidence show with fusion rates in people with diabetes? Something like that. And so So yeah, I mean, that's why it's important to read multiple different looks at the same question, the same research question.
Yep, that's a good point. What is your talk on for Stryker? Is it?
I think it's titled how the importance of evidence-based surgery or evidence-based medicine in spine surgery.
Nice.
So I could probably just use your slides,
Yeah.
put my name in the corner, and like everything would be just perfect, right?
Yeah,
So
exactly.
yeah. It's for a pre-fellows course. So folks who are not yet in fellowship, our fellow from next year actually may be there. I have to check the list, but
oh yeah, yeah, because I did. It's here in Chicago, right? So I did that a couple of years ago.
Yeah.
Yeah.
Oh, you did? You were at that course?
Yeah, yeah, yeah. That was a good one.
It's good. It's good.
Yeah.
It's good. We didn't do it last year, obviously, but
yeah, that's right. Because I remember you and Savage were there, I think.
Yeah,
like
yeah,
hosting.
Savage's course. Yep.
Yeah.
So yeah, we're doing the same thing.
Cool. All right. Well.
All right. Great talk, Tree. Thanks,
Yep.
man.
Yep. Thanks. I guess anyone else, let me know if you have any questions. I actually got to run now because I got to get home. But feel free to text me or anything. All right. See you guys.
Thank you.
Thank you.